All right, Day. Let's go ahead and get started. Uh, Welcome everyone. My name is Tyrone Squires, and I am Managing Director of Transparent RX, a fiduciary model pharmacy benefit manager. And with me today is Day Lee. He is an attorney and also a PharmD. Now, about our backgrounds and our experience, you've probably already did your homework on that, so I won't spend not even 30 seconds on digging into that. We want to dive right into the content that is all about you today. We will have time at the conclusion of the webinar to kind of maybe address our backgrounds a little bit. Here is the agenda for today. We're going to try and keep that as best we can to about 30, maybe 35 minutes or so, and then leave at least 5 minutes or so for any questions that you may have for us. About those questions, during the course of the webinar, we want it to be interactive as much as we can. There's a couple ways you can get questions to us, and we'll be monitoring those as they come in. But you can raise your hand, and you can see the raise hand feature there on your control panel. And then you can also send us a message via chat. So we'll have everyone muted. If you raise your hand, that means that you want to be unmuted and you want to pose your question live to everyone here on the webinar today. So with that, let's just get right to it, shall we? So listen, when we ask a plan sponsor or an employer, what's your primary concern around pharmacy benefits, and then inevitably it's going to come back to something either directly or indirectly around price. But what we're going to share with you today is that addressing that concern isn't necessarily about getting bigger discounts off of AWP or winning more rebate dollars. The primary issue is information asymmetry. And Axios, you may be familiar with Axios, the journalism outlet. They had a fascinating article that they put out late last week around PBM coalitions and kind of the secrecy behind those coalitions. And this goes to the core of what information asymmetry is. It is essentially two parties, one is a buyer, one is a seller. And the seller has access to information that the buyer does not have access to. And that seller, instead of sharing that information to put its client in a better position to determine whether or not their relationship is fair or their cost is reasonable, withholds that information. Owning a PBM, I get these nice little tidbits, it seems almost on a daily basis, that just reminds me of how much work we have to do. This is a perfect example of information asymmetry at play. The coalition in this case is saying, listen, we can't share the information. It's proprietary, and we don't want it to get into the hands of our competitor. And it's reasonable. It's a reasonable explanation, but it doesn't hold water. It sounds reasonable, good explanation, but the truth of the matter is that PBM coalition doesn't want its clients to be able to have the data to determine whether or not the prices that they are paying are fair. That leads me to the status quo. And the status quo says this, and it's much more complicated than what you see here on the screen, because some arrangements that I'm about to explain could involve the medical benefit side as well. You've seen credits on the medical administrative fee when you forego rebates. Same game, different name. Plan sponsors enter into an agreement with a pharmacy benefit manager that calls for artificially too low PBM administrative fees. And when I say artificially too low, I'm suggesting anything below $6 per paid claim is artificially too low. Now, that doesn't mean that if you're paying $5 that you're not receiving radical transparency. What I'm suggesting is the further away you get from that $6 per paid claim administrative fee, and the administrative fee is the fee that a health plan sponsor would pay to have claims adjudicated. To have a member web portal for pharmacy benefits, to have a mobile app, to have access to an account manager, 24/7 call center. That's what the administrative fee is for. And when you don't pay that fee, or when you pay $1 per paid claim, and you could factor that out to a per employee per month or a per member per month, it's gonna, at the end of the day, it's gonna come out to be pretty close when it runs through underwriting. And so when you don't pay that $6 per paid claim, or you pay, $1 or $2, that essentially gives the PBM the green light to augment that artificially too low administrative fee through hidden cash flow methods, right? And so the first one that I want to really, really quickly address is spread pricing. Spread pricing is not accidental. It's not a billing error. A spread is the difference between what you or your clients pay and what the pharmacy is reimbursed or paid by the PBM. Any difference, the PBM is going to keep for itself. That is the markup that you see here between both the retail and the mail. Now, the state of Ohio, a couple years back, decided, you know what? We keep going in and we keep winning bigger discounts that we're negotiating off of AWP. We're also changing the pricing benchmark to ASP, and we're getting bigger minimum rebate guarantees. But why do our costs continue to go up? So they decided we're going to pivot. We're going to continue to measure performance by discounts that we negotiate with you. But we're also going to start looking at how much we're paying you. That goes back to that information asymmetry piece that I talked about, addressing that. The state of Ohio uncovered almost $250 million just here. Hadn't even touched on the rebates yet. $250 million just in spread pricing. Now, if Greg were here today and you're having a conversation, you would soon discover that it wasn't necessarily, we're saying this information we've never, and there it is again. There's that key word, information. What we're saying is it's information we've never had before. He would tell you it's information we never demanded before. It's information that we never thought to evaluate before. I'm going to share with you here when we can, towards the end of the webinar, how powerful or how low cost can be when you have access to the right information. You might be surprised to find out that the PBM's take home is higher than what the drugs cost. Rebates are another example that contributes to that. And so the problem with the rebates, again, there's a lack of information around the rebates. How many of you are being paid rebates, but you don't know what each claim that is eligible for a rebate, what it's earning? The reason is here. The reason is here. Again, I have to go back to it. PBMs have been making it difficult to ascertain what their fees are. They start off with the artificially too low administrative fee and then augment that, and rebates, manufacturer revenue are a big chunk of that. When we negotiate with manufacturers, we start here and we relabel or rename those dollars. And I say we. Listen, I own a PBM. I can't exclude myself. This is a part of who our industry is. But we're having this webinar today to change that. So the manufacturers say, we're going to start off with X dollars. How do you want to allocate those funds? That allocation is driven by PBMs. And they can start here, and then those funds in here, and then the PBM passes back only the formulary rebates, but then keeps that part. This is the information that would allow you to start to see or eliminate the part that the PBM is keeping. This is a rebate remittance report. And we'll touch on this here in a second. But essentially, what happens, not essentially, this is exactly what happens. Manufacturers, based upon their contracts with us, will send us rebate dollars via ACH. Along with those dollars is an explanation of payments. And, and it details every claim that was eligible for a rebate by the RX number, the date, everything that you need there to determine net cost. But then the PBM will then pass back a portion of those dollars to the client without this level of detail. And so when we share this with our clients, obviously plan ID, RX number, NABP, NPI, all that information is populated, but we have it redacted or removed here today for obvious reasons. This, just to give you an example, and this information was made public about 2.5 years ago or so. And Express Scripts sued Kaleo, which is a specialty drug manufacturer, because Kaleo refused to pay rebates that it allegedly owed to Express Scripts. And here's why I share that with you. Again, this is public information. You can go out and research it yourself on Google. The formulary rebate is dwarfed by the administrative fee. This administrative fee is not the same administrative fee that I alluded to at the very beginning around the per paid claim fee. This is a manufacturer administrative fee. It's a rebate that's been relabeled. And so if your contracts or your client's contracts don't address these dollars, then guess what? Your net costs go up for that particular claim because the PBM is keeping a big chunk of it. And so with that, I'm going to turn it over to Day.
Thanks, Tyrone. All right. Vertical integration is complicating the overall industry and contributing to what Tyrone alludes to as information asymmetry. As you can see here, every major PBMs are vertically integrated from plan sponsor level to specialty pharmacies. Notably, each major PBM now owns rebate aggregator. Caremark launched Zinc in 2020. ESI owns Ascent, which is based out of Switzerland. Optum recently launched a MISAR, which is based out of Ireland. PBMs also outsource rebate aggregation function to another PBM, which in turn may subcontract with its own rebate aggregator. So there has been a series of actions taken by state and municipality plan sponsors against PBMs because they're getting educated, they're finding more about PBM's business. But one would assume that there will be more transparency from PBMs when they contract with government bodies. Well, that's not the case. Let's talk about the most recent developments involving Centene. As you may know, Centene is one of the largest, in fact, I think it is the largest Medicaid managed care organization that at one point served as MCO for 30 states, Medicaid agencies. However, states including Ohio, Mississippi, Kansas alleged that Centene overcharged the state Medicaid. In turn, Centene settled with those states and reserved over $1 billion for the future state settlements. The most recent settlement that Centene entered into was with Kansas. And with that settlement, it included manufacturer rebates that are not returned to Kansas state Medicaid. So let's turn to the next slide. So what is manufacturer rebate? I mean, there are different types of rebates, as Tyrone mentioned previously. Plans and plan sponsors, they must receive full value of negotiated rebates in order to reduce their total drug spend. However, the gross to net bubble has been going up in the past several years. Okay, so what is the gross net to net bubble? It's a dollar gap between the gross sales at brand name drug list price and their sales at net price after rebates. So in 2020, the gross to net bubble was projected to hit $187 billion. So where is the money? Well, that is the $1 million question, right? So let me show you how rebates, the flow of rebates that are not being captured at full negotiated price. So what you see is a cover page of the Broward County's audit report. So in that audit report, they show that Optum, the county's PBM, used its own rebate aggregator, which in turn contracted with Express Scripts. The report concluded that Optum did not report rebates collected by Optum's rebate aggregator at the time, as well as rebates retained by ESI. And Optum, which obviously entered into a settlement with the county. So again, every major PBM owns its own rebate aggregator. Now, our firm, Friar Levitt, we recovered approximately $6.5 million in rebates on behalf of a Part D sponsor from a PBM who is now owned by a publicly traded company. So it's an example that the rebate game is even prevalent in Part D space, which is heavily regulated compared to commercial space. So what you see in this slide is a typical definition of rebates. I mean, it leaves so many loopholes that can be used by the PBM against the plan sponsor. What if the PBM contract with a manufacturer just rebates another name? I mean, it happens and is very common. So you cannot capture rebates that are being passed on to PBM unless your rebate definition of rebate includes all the different jargons that PBMs use. Okay. Now, not only that, the rebates that are being paid on your drug claims may not even be passed on to you, because the manufacturer may say to the PBM, hey PBM, I'll give you, for example, give you 10 million in rebates if you increase the market share of my drug. Okay, so that is another name of the PBM, of the rebate. So what do you need to do? You need to have strong contract terms around the rebates and the rebate audits. Otherwise, you will likely have a contract that only, incentivize the non-transparent relationship. Okay, yeah, you need to start, you need to take control of your contract, and you need to audit in your own terms, audit the PBM's rebate activity. Okay, so where do you start? The starting point is the RFP. You need to dictate the terms of the RFP and have PBMs to bid against each other. The key is to stay close to your key contract terms, and do not delegate your contract negotiating and drafting to PBM or PBM incentivized broker. Okay, that's the key. That's where you start. And let me turn it over to Tyrone. Tyrone, you have the floor.
Yeah. So real quick, one of the biggest mistakes that I see is that the contract portion is addressed towards the end of the RFP process. Or even worse, the vendor is selected before the contract terms have been memorialized between the PBM uh, and the plan sponsor. The contract, and so all of these kind of hidden cash flows, the kind of PBM self-dealing, that starts with the contract. Please put the contract front and center at the very beginning of the RFP. That is, if you want radical transparency. If you don't care, keep the contract at the end and you won't get it. But what we're trying to get to today is, how much is the PBM putting in its bank account for the services you or your clients hired it to perform? We're not asking too much, right? You're not asking too much. We're not talking about net income. And for the larger PBMs, that's public information anyway. We don't need to know what your payroll is. We don't need to know what you pay for real estate. We just want to know, what are we paying you? And so that number can be defined or calculated by this formula that you see here. And we call it internally earnings after cash disbursements. Everything in green at some point lands in the PBM's bank account. And even here, I could add DIR fees and couple that with dispensing fees, direct and indirect remuneration. Everything in green at some point lands in the. If you don't know what DIR fees are, go out on the internet. There's a ton of information about those, and a lot of different opinions as well. But everything in green lands in the PBM's bank account. A cash disbursement are dollars that leave the PBM's bank account. An example of that would be when we reimburse a pharmacy that has dispensed a prescription to one of our plan participants. That is a cash disbursement. A share of rebate dollars, remember that kind of that flow of rebate dollars where it, with the manufacturer, it starts with formulary and administrative and all that, and then the plan sponsor ends up with only formulary, but the PBM is keeping market share and everything else, right? So a cash disbursement, another example would be the dollars that a PBM passes back to its client in the form of manufacturer revenue or rebates. Whatever's left over is what the PBM is paying itself. And so we're suggesting a new path here. At a minimum, radical transparency. Any PBM that says that they are transparent or radically transparent, yet you don't know how much they're being paid for the service that is they're not radically transparent. There may be some resemblance of transparency in that relationship, but there's still too much information asymmetry at play if you can't determine how much they're being paid. I mean, think about it. If I go to McDonald's and I get a Whopper and some fries and what, I know what I'm paying McDonald's. If I hire a plumber, I know what I'm paying that plumber. The new path says this: PBMs are paid a reasonable administrative fee, started at $6 per claim. It could go up to say 15, maybe 16, $17 or something, depending on the services that you want to provide to your members. It may be scary, but I promise you, if the PBM is eliminating the hidden cash flows, your costs go substantially down. We took over this client in 2020, right at the beginning of the pandemic. And when we brought them on, they were paying essentially $58 per member per month just for their pharmacy benefit. At the end of year one, all in, net of rebates, net of our administrative fee, the cost had dropped to $23.12. I talked about earnings after cash disbursements. In other words, the PBM's take home. What is it being paid? In this example here, the earnings after cash disbursements for Prime is $35 per member per month. That is the difference between our costs and theirs. All because we're taking a flat admin fee and we're not benefiting from spreads and we're not benefiting from rebate dollars. Look at this again. This Prime's take home was higher than what the drugs cost. It was higher than the ingredient cost. A lot of folks say PBMs are adding cost to the supply chain. They don't really know how. Unless you know how, you can't fix it. You know how now. And so I'm going to wrap up here. Stick with me for the next 30 seconds. I'm going to wrap up. And by the way, I always like to source my information or provide the testimonials when I provide numbers, because I don't want you walking away thinking this, Day and Tyrone, they're full of crap. There's too much of that already in the industry. We don't want to be a part of it. Where pharmacy benefits are concerned around change, and we're in the middle of it right now, there is going to be help for public institutions and organizations. There's going to be much less help for commercial plan sponsors. You're on your own. There's going to be some help, and there's going to be more data required to be given to you, but that data is useless if you don't have the know-how around change. If you want to get to below $25 per member per month, I don't care if you're paying $150 per member per month today, it is possible. And it is possible without disrupting your employees and having them go somewhere else because the benefits are better. It's just about becoming a bit more sophisticated. 3 things need to happen. First, awareness of the problem. Everybody knows that the PBM industry has some work to do, and I'm being generous here when I have some work to do. But everyone knows there's a lack of transparency in the industry. But then the second piece of that is you got to have a desire to fix it. That's the preparation stage. So we all know that that there's work to be done around transparency in the industry. Great. Now you got to have a desire to address that problem. And then the third piece is the toughest piece, the maintenance piece. That's the know-how. Working knowledge isn't gonna cut it. That's naive to believe that because you have working knowledge of the PBM industry, that you can actually fix the problem. If you want to fix the problem, we can help you. Whether it's through education, fiduciary PBM services, or you need legal help in doing that, we might be able to help you. Our contact information is there on the screen. You can go to LinkedIn. You can do a Google search. More than enough will pop up about what we're doing in the industry to affect positive change for the greater good. We appreciate your time. We're going to stick around just in case any questions come in, but you should get a recording of this webinar in your email inbox tomorrow morning. We appreciate the time. Be safe and happy holidays.